Dr. Richard Krasuski from Duke University. Thank you for joining us. First thing I'm going to talk about are the goals of treatment in patients with pulmonary arterial hypertension. So back in 2013, we focused predominantly on New York Heart Association or World Health Organization function class as a real predictor of survival and also the determinant in terms of what we were going to use for medical therapy. However, there are a number of variables that we use beyond that to really decide who we're going to treat and how aggressively we're going to treat them. So our goals really in trying to get patients to and determine what their responses are is, first of all, function class. We want to get them down to a World Health Organization function class 1 or 2. Echocardiographically, we'd like to see ideally a normal or near normal RV size and function. Hemodynamically, we really want to try to get the patient up to a cardiac index of at least 2.5 liters per minute squared and get their right atrial pressure below 8 millimeters of mercury. We'd like to see them walk, as far as their 6-minute walk distance, greater than 380 meters. Cardiopulmonary testing, you can see some of the criteria in terms of what we ideally want to get them to be able to exercise to. And then finally, natriuretic peptide levels. Turns out that the right side of the heart also has significant stretch under hemodynamic stress, and ideally we would like to get them down to almost normal levels. So that's going to be a BNP less than 50 or ideally a pro-BNP less than 300. Here is what the guidelines have shifted to in terms of looking at a chart rather than just looking at a function class to know how you're getting your patients to with medical therapy. On the left side of the screen, you can see the patients that ideally are getting to their goal. In the middle of the table, you can see patients who are at intermediate risk, and finally on the right side of the screen are the high-risk patients. So again, we're going to look for clinical signs of heart failure. If they're not present, things such as peripheral edema, fatigue, etc., then we're going to feel comfortable that we've gotten them to their goal. We're going to look for progression. Ideally, we don't want to see any progression of symptoms. We really want to see regression. But thirdly, syncope. If a patient is having episodes where they're passing out, that's a poor prognosticator. That almost immediately takes them to the status of a function class 4 patient. So if they have occasional syncope or repeated syncope, that's going to be considered more risky. As we mentioned earlier, the WHO function class is going to be important. Ideally, we want to get them to class 1 or 2. Obviously, the highest risk patients are going to be in function class 4. A 6-minute walk distance, you can see the extremes here, greater than 440 meters is really ideally where we want to get them to, but less than 165 is certainly a very high-risk patient. Cardiopulmonary exercise testing, as we mentioned earlier, natriuretic peptide levels, as I mentioned earlier, imaging. Ideally, we want to look for the absence of a pericardial effusion. If there is a pericardial effusion, that signifies a patient who's at increased risk. And then the right atrial area. Ideally, we want to see somebody with a smaller right atrium, less than 18 centimeters squared in size, as opposed to if they're over 26 centimeters, that's a sign of hemodynamic problems. And then the hemodynamics themselves, as I mentioned earlier, we ideally want to see somebody get over 2.5 liters per minute per meter squared and get that right atrial pressure below 8, and that's really the goal of treatment. So in summary, we ideally want to get patients as asymptomatic as possible. We want to improve their right ventricular size and function as much as we can. We want to maximize their hemodynamics. We want them to be able to walk further. These are all goals of therapy, and ideally we want to strive for normalizing these, not just improving them. And I thank you for your attention.